So very quickly, we are so grateful to have our next speaker with us. Natalie Yerlett is a highly specialized pediatric dietitian based in Great Ormond Street. She's also one of the leading pediatric celiac disease specialists in the country. If you've ever used the BDA gluten-free sheet, thank Natalie, because she is a primary author. She also has a passion for studying dermatological disorders and how they relate to the gut function and gut microbiome. And she's a supplementary prescriber as well. And we're very grateful to have her here today to talk about the fascinating emerging area of the gut-skin axis. Thank you, Natalie.
Thank you. Thank you so much for inviting me. And sorry for my keenness coming up too early there. So today I'm going to take a slightly different detour, I think, from what we've heard today. So I hope you've still got some energy and some concentration left to hear my words today. We're going to talk about the skin-gut axis, which is something that in the last year or two has become something really fascinating to me as a gastro-dietitian who sometimes wears a dermatology hat. So we're going to just briefly touch on microbiomes, because I can't talk about this without talking about microbiomes. But also skin structure. It might be something not many of you have thought about for a while, so I thought we'd take back a step and have a look at that. The skin-gut axis, and also just some of the questions that I've had in my practice and some of the questions that I have moving forward in my practice as well, and some conclusions as well. So what is a microbiome? And I often find that the gut microbiome gets all the attention. You know, it's like the cool kid at school when it comes to microbiomes. Okay, so but actually our skin has got its own thing going on. So the skin microbiome is its own unique environment of just billions of microorganisms. And these microorganisms are bacteria, fungi, algae, archaea, other viruses, plasmids. But what's just like the gut, what is really important to note is that the skin microbiome isn't just the microbiota that exist on there, it's all the other stuff that comes with it. So we're thinking about the things that these microorganisms make, vitamins and different things, but also all of their genetic materials, their acids, all of the things that they give off as well. So it's like a big community of all of the things living on the skin. Now, variation does occur within the same species of bacteria and different microorganisms. So it's really important for us when we're thinking about the microbiome to think strain specific. And that's the same with the gut microbiome and the skin microbiome. For example, I didn't put some, and do forgive me because some of my pictures do get a little bit squeamish. I am 0 on the scale of squeamish, so do forgive me if you need to look away at any point in time. But if we think about acne as just a really simple example, one of the strains of bacteria that can cause problems with people with acne, one of the strains actually produces something that causes acne, and one of the strains produces something that helps with acne. So when you're thinking about probiotic treatment in acne, for example, we really have to be detailed in what we're thinking about for treatment. Now, it's also important to note that just like the gut and the skin, they both have lots, thousands of different microbiota, but only some of them are known to be pathogenic. So really, most of the stuff that's going on our skin and in our gut is really beneficial or neutral to us as well. There's just a few species that can be really pathogenic, and that's similar within the gut and the skin as well. Now, it's really important, and I'm a pediatric dietitian, so I've realised over the day that there might not be many pediatric dietitians in the room today, but I'm often thinking about, well, how can I intercept my patients? Where can I help them the most? And I think when I'm thinking about the microbiome, where it starts for the gut and the skin, it's important for us to think about the journey for a child. So we're thinking about right from in the womb, what is the mother's diet, where does she live in the world, what is she exposed to, and what does the baby then become exposed to? Particularly when the baby's born, how is the baby born? C-section, vaginal delivery, all of these things impact the microbiome of the baby. And then how's the baby fed? Breast milk, formula milk, all of these things play a different part. So each little sort of segment in time, or these pinch points in time for a developing embryo and a baby, collects up different microbiota as they go along. So every single person in the room has just got a totally different, unique microbiome. So gut microbiome and skin microbiome. Now, dysbiosis is really what, as a clinician, I suppose we're most interested in when it's thinking about treating different conditions that are affected by the microbiome. And this is just a term to describe an imbalance in the microbiota, variety within the gut or the skin. And it can be in a variety of ways. So it could be that just the beneficial bacteria are reduced, so some of the beneficial strains are not being proliferated. It might be that actually we've got over-proliferation of, like in the acne, for example, you've got an over-proliferation of the bacteria that causes acne. Or it might just be overall a reduction in the variety of the microbiota. Now, I won't talk too much because I realise I could ramble on all day about these things, but the potential benefits of the gut microbiome are well documented, and I'm sure as gastro-dietitians you're all really familiar with these things. But really the same that applies to the gut may apply to the skin, and that's really where I'm interested in. So we know that the gut microbiome, if we can look at the different strains and what they do in the gut, can affect the gut barrier integrity, for example. We know that they can protect us from pathogens, so it's like a first line of our immune system. We know that digestion of fibre, particularly complex polysaccharides, for example, then give off really beneficial, almost essential in many places, actually vitamins and short-chain fatty acids that then go on to do other things in our body that we just couldn't function without. They produce enzymes that also particularly change the acidity of the lumen of the GI tract, for example, and we see that in things like C. difficile infection as well. Now, if anybody doesn't know about this already, and you may well do, but I just thought I'd put a quick slide on there for the updated guidelines from the WGO, and this is all the fantastic resource for going to somewhere where all of the evidence and the sort of strain-specific trials and what they've been looked into and how, just a really great resource for looking at the evidence base for probiotics in any condition. So if you've not looked at that, it's online. They only ask you to give your name and then they give it to you for free. So have a look at that if you've not seen that before. Now, what is interesting to me, and I've touched on it a little bit there about the childhood development process through from the womb, but really what affects these microbiota on our skin, in our gut, and can we then influence how we look after patients or ourselves to make this improvement? So really, I wrote loads down, but I thought I just ran out of room in the end. So actually things like probiotics, of course, lots of interest in probiotics, prebiotics and fibre, but also other things that you can't control, genetics, whereabouts you live in the world. And we see that different countries have different sort of baseline microbiomes. We also know that dietary variety, hormones, the antibiotic use, all of these things are impacting on which variety and how much and what strains are in our gut and on our skin. Now, these are the ones that I'm really interested in my clinical practice. So I've put down probiotics, prebiotics, fibre, and so it's all the things a dietitian would be thinking about, of course, but also inflammation. And I'm going to talk a little bit about why that's important in my patient cohort. But inflammation is really at the heart of many skin conditions and many gut conditions. So if we can work out how to really impact inflammation, we can really help with many of these clinical symptoms and diseases that we see in our patient cohort. So I'm going to take us to the skin now. Now, what is great about the skin microbiota is that it's just a bit tougher than the gut microbiota. So it's like they're all a bit harder. Okay, so they have just a much tougher time. If you're a bacteria and you're inside the gut, it's nice and dark, warm, moist. There's lots of food passing over the gut lumen all the time, so you're well nourished. It's just this nice, cushy place to live as a microorganism. Now, the skin is totally different. It is dry, it is acidic, it's sweaty. It might be exposed to UV light, for example, and it might be different in different parts of your body. But also the nutrients that are available on the skin are totally different. So, of course, in your gut, whatever you eat are available to the microbiota in the gut. On the skin, really all you've got is a bit of grease, from your oily glands, and that's about it, some base proteins maybe. So the bacteria and the fungi that we see on the skin are much tougher, much more, able to cope with these harsher environments. And what we do see is that these properties that they've evolved that exist in these harsher environments makes them really stable. So you often, once they're there, they're quite difficult to change and to move. But interestingly as well, and for everybody sitting here now thinking about this on your skin and what's happening in your body, is actually different parts of your body have different microbiomes. So skin that has hair on, for example, totally different microbiome to the skin that's on the face. You know, shoes and socks, totally different microbiome that's in your feet, and everywhere on your body has this different area, this different variety of microbiota. So it's really important when we're thinking about skin and disease, how this affects, you know, what are we treating, and actually thinking about it as a global picture as opposed to just a snapshot. So let's take a look back at skin structure. Now, it's really fascinating to me, but it's three main layers. So we've got the epidermis at the top, and I always say to my patients, this is like the waterproof jacket. So this is the sort of the waxy jacket that's over your skin that is just protecting everything on the inside. Underneath that, we've got the base, the middle layer is the dermis, and in the dermis we've got lots of nerve endings. This is where you produce your sweat glands and the hair follicle starts. And at the bottom of that is the adipose tissue, so where you've got your fatty sort of cushion, if you like. Different parts of you might have different amounts of that as well, but it's a really complicated structure. And you might be thinking, as gastro-dietitians, just like I do, it reminds you of something. You know, it reminds you of the gut mucosa, maybe. So it's the largest organ in the body, and if that's the only thing you remember from today, that's always handy for a pub quiz. So the skin is the largest organ in the body, and actually it has a continual turnover of cells. So from that base layer up to the top, every 2 weeks you sort of get almost to the top, and then the last 2 weeks just finishes off and sheds away. So every sort of about 3 to 4 weeks you get a totally new set of skin, which is incredible, isn't it? And we know that it can protect us from damage, infection, and drying out. Now, that doesn't sound too great, but in some of the children I look after where their skin is totally dry and all broken, actually maintaining their hydration, especially as infants, is a real challenge for me in the sort of neonatal period. So drying out, we take that really for granted, but actually your body's protecting you from drying out all the time. But most importantly, and for me thinking about my clinical practice and how I'm going to take this forward in my research ideas and things, is that how the skin communicates with the immune system. And the skin has its own little bit of an immune system going on, but actually is the communication between the microbiota on the skin itself, back to your body, your brain, and your immune system is just fascinating to me. So what can go wrong? And as I've alluded to, sometimes this does really go wrong. And my next slide has got some pictures of some of the little patients that I might look after. So if you are a bit squeamish, do look away, and I do apologise. But I think it's important for you to understand maybe the severity of what I am dealing with and why what drives me to help these patients along. So we have inherited conditions. So I look after children who are born with a genetic condition where they have a gene mutation, might be inherited, can also be spontaneous, where something in the structure of the skin is just missing or not there quite enough, and I'll talk about that in a little bit of detail. Or it can be an acquired condition. So you might have something like eczema, for example, or acne, or rosacea, something that's affecting the skin, but it's a more temporary situation, and actually maybe we could treat it and we could get rid of it. So there are kind of two different types of dermatological treatments. And these are some of the patients that I look after. So I look after patients with epidermolysis bullosa who have difficulty with just maintaining their skin, and I'll explain why in a moment, and patients with Netherton syndrome, ichthyosis, and other genodermatoses. So really, you know, the super severe end of the spectrum when it comes to looking after and maintaining life, actually, in those first few months. That's my challenge, is keep them alive. So when it doesn't go well, the skin structure, and we just saw those pictures, I'm going to just focus a little bit on EB now and sort of what happens. So if we go back to that 3-layer structure of the skin, I like to think of it as that there's like little Velcros that keep each of the layer on top of one another. So you and I are all sitting here with our Velcros really working really well. You might get a new pair of shoes, and that might just rub a little bit, and it might just rub some of those Velcros off, and you get a blister. Super painful, isn't it? Super painful. But actually, the children with EB have this all over their body potentially. There is a spectrum, so some children are quite severe, and of course, there are some children who are quite mild, and it depends on which genetic defect has occurred. But what they're missing is some of those Velcros. So the Velcros hold the skin on, and they might have totally none of that collagen 7 Velcro, or they might have patches of it, and that determines how severe they're going to be. But probably the patients I spend most of my time looking after are the children that have none at all, and of course have chronic wounds, chronic pain, and really difficult time. Now, why has a gastrodietitian been asked to look after this cohort of patients? And that was my exact question when they asked me to do it about 8 years ago. And I was like, but I'm a gastrodietitian. And of course, I started to look after the patients with the dermatological conditions. And I thought, oh, I get it now, because they've all got gastro problems. And really, that's their biggest difficulty, apart from their skin. So they all have reduced intake, difficulties eating. Often this level of this collagen 7 Velcro, it doesn't just affect the external skin, it actually affects all the mouth, the esophagus, the gut, the anus, just everywhere that there's a bit of mucosa. And we see that in my patients. So some of my patients may have esophageal sloughing, where they actually just email me, they say, Natalie, or where they've coughed up the lining of their esophagus onto a piece of paper, you know. So sometimes it can be really difficult to manage the GI symptoms that the patients have. But they all have constipation, and really bad constipation. This is my some data from a while ago now, but it's my cohort of patients where we looked at just how many of them have GI problems, and pretty much, I would say, just anecdotally as we're looking after them, I'd say 99% of my patients have such severe constipation that they have to take 8, 9, 10 sachets of Movicol a day. Now that, I'm talking to adult dietitians, so that you might be thinking that's not too much, but when you're 2 or 3, that is a huge amount. We also see things of esophageal reflux, gastroesophageal reflux, and really severe. So patients who, like I said, are sloughing up their esophageal lining, but also bloody aspirates, those sorts of things. So reflux, not just in the standard sense, really, really cranked up. And then we can see patients with diarrhea, protein-using enteropathies, and different things as well. But that's a bit more rarer, and I like to think I'm managing them maybe a little bit better. Constipation is the main issue. So they all have it. It doesn't matter how severe they are, how mild they are. Constipation is the issue. So, and of course, there's lots of things that feed into constipation, and you'll all be aware of, I'm sure, with higher fluid requirements. So we said, didn't we, that if your waterproof jacket is missing, you dry out. So they're all drying out all the time, and then they don't drink enough. So they're all a bit dehydrated all the time. They might have absolutely severe chronic anemia involving IV iron infusions, really severe anemia. And of course, they're all on iron supplementation that then causes constipation. They might have difficulty with their oral mucosa, so they can't eat enough food. Then they might have blisters, and they might get blisters in their esophagus, in their anus. That prevents them from doing a poo with ease, so then they'll just hold on, and then that makes it all worse. But what is really key, and what is really fascinating to me now, is actually all of the patients that I look after, because they have these wounds on their skin, they have just constant antibiotics. So probably once a month, once every couple of months, the severe patients have antibiotics, and some of them have prophylactic antibiotics. And then on top of that, they also have inflammation. So their body is constantly in this sort of acute phase mode where they're fighting infection, they're trying to heal. It's just chronic all the time. And I look at the blood results of these patients all the time and just see this chronic CRP raise. And then sometimes it'll really spike. So, of course, with all of the things that I've just talked about, what is, with constipation, poor intake, drying out, difficulty with lots of antibiotics, inflammation, it really started to occur to me that these patients were probably all at real high risk of dysbiosis. So this was a few years ago now, but I thought, actually potentially, I also wondered if they were vitamin K deficient. So I thought, if you have all antibiotics all the time and actually probably destroying the microbiota that create vitamin K in your gut, are you at risk of vitamin K deficiency? Is that even something that we can check? And this was a question I asked a few years ago now. And of course, the patients that I look after bleed a lot. So I thought, well, this has an impact on blood clotting, but also bone health. We know that vitamin K is integral now in ensuring bone health as well. So I looked at my patient cohort over a few years and found that 40% of them had just frank vitamin K deficiency, and now I just give them all vitamin K all the time. And actually just anecdotally, I can see that they don't bleed as much, and they manage much better for surgeries and things like that as well. So bearing all that in mind, let's think about this gut-skin axis and how the two of these things can communicate, and how I can maybe think about this moving forward as to how I can help my patients who have this dreadful skin disorder. So we've talked about the skin structure, and I know you all know the gut structure, that actually probably when you think about it are really similar. And one of my gastroenterologist, Neil Shah, David, who you mentioned yesterday, said to me many years ago, he said, if it looks like that on the outside, Natalie, it's going to look like that on the inside. And it just stuck with me forever, ever since, actually. But when we look at the structure of the gut and the skin, they both have this sort of epithelial cell layer on the top of what's exposed to the exterior environment. So they have these similarities with this epithelial cell structure. And that's really the first line of defense. So we were talking about, dare I say, leaky gut. Yeah, I'm not going to say it. Intestinal permeability, but actually this is also true of the skin barrier. So their epithelial cells, we need to maintain them in the gut mucosa, but we also need to maintain them in the skin epithelium, as my patients, as you can see, that's what they're fighting against. These really act as first line of defense. So as soon as you break those structures down, of course, microbiota can enter. And yourselves, if you've got a wound or something, actually, the worst thing that you can do is think, oh, actually, I'm going to rub some mud in it. Or so, you've broken that barrier down, and actually you're potentially introducing pathogenic microbiota into your bloodstream. And both the gut and the skin have these immune modulating effects, and that's what's really fascinating to me. So the skin-gut axis is this bidirectional relationship. So the gut can influence the condition of the skin, but can the skin also influence the condition of the gut? And this sort of bidirectional theory is what's really interesting moving forwards. Now, we already know that the skin can be influenced by the gut. So if you think about some of the conditions that we all look after in common, things like celiac disease, for example, we know that if some patients may have ingestion of gluten that then produces dermatitis herpetiformis. So something is happening in your gut that's then impacting on your skin. But also things like allergies. With some children I look after will eat food, and then they will have a skin reaction to that food. So we know that there's this communication between the gut and the skin already. It's obvious, But we also know that the skin might impact on the gut, and that's sort of where this emerging evidence is coming from. So, for example, vitamin D production in the skin that you all, hopefully, especially on a day like today, are making from the sunshine, then can impact the gut autoimmunity and the integrity of the GI tract. So this skin microbiome can protect the skin from infection, as we said, and it kills off invading species. Now, what is really fascinating is that the skin has this really amazing way of just knowing which of the bacteria and the fungi does it want to have on the skin and which does it not want to have on the skin. And it's actually really clever at trying to encourage the good bacteria and the microbiota and trying to destroy the bad ones. But of course, sometimes it's overwhelming and the skin just can't keep up. The skin also produces anti-inflammatory chemicals, just like the gut, and also it can produce these chemicals, as we talked about, this intestinal and this skin barrier permeability. So it can actually produce chemicals, the microbiota produce chemicals that tighten up the tight junctions in these epithelial cells. So really important when you're thinking about skin or gut conditions that are caused by breaking down of that barrier. Now, this is a dreadful slide. I'm really sorry. The writing is really dreadful, but I just wanted to put the picture up for you, because you can see here that this is a lovely sort of, I mean, obviously there's a bit skipped out in the middle here, but this is the gut at the bottom, and this is the skin at the top. And they're both served by lymphatic vessels, blood vessels here. And on this lovely, really lovely, healthy microbial person here on the left-hand side, we've got loads of mucus in the gut. We've got really, these tight junctions are all, really, really intact. There's no permeability. And actually, there's no inflammatory reaction. There's no cytokine release, overproduction of anything that's going to cause any problems. And the same goes for the skin. So we've got a lovely, diverse microbiota on the skin here, and the same, you can see no inflammation. Now, on the right-hand side here, we've got someone who's potentially got dysbiosis. So dysbiosis of the gut and dysbiosis of the skin. And in the gut, it showed there's no mucus there anymore to protect it. The epithelial cells and the tight junctions are broken down, the barrier is broken, and we can then see the reactions occurring potentially for inflammation. And we see the same thing here with the skin. So there's dysbiosis on the skin, and then there's inflammatory markers, cytokine production that causes inflammation. So that might be something like eczema, for example. Now, antibiotics, I can't really talk about the skin microbiome without talking about antibiotics. Now, we know that they have a massive impact on our gut microbiota, but they also impact on our skin microbiota. So now, it's a bit of a double-edged sword, in that often if you have a terrible wound or a terrible burn or something, and you go to the A&E department, probably the first thing they will do is give you some antibiotics to prevent you from getting sepsis. But what we also know, and there's some evidence to show that, so for example, vancomycin, when you're given that to treat a bacterial infection of the skin wound, actually can then inhibit the genes that actually help you to heal that wound. So there's this real double, are we making things worse, is essentially the situation that could be the case. Now, we know intestinal dysbiosis has been associated with different dermatological conditions, and some of these conditions have some emerging quite solid studies, some really good evidence now building, and they are acne, as I've said, atopic dermatitis, so eczema, psoriasis and rosacea. And we know that actually potentially the patients who have these conditions have a dysbiosis. So when you swab the skin of somebody with eczema, for example, you see that there's this dysbiotic variation in the microbiota. But what's not quite clear is if the dysbiosis is causing the dermatological disorder, or if the dermatological disorder is caused by the dysbiosis. And that's, I think, really the area that we need a bit more evidence and a bit more data on. But we know, for example, we can see that if you just, in some studies, not enough to change practice, but we can see that there are all these studies emerging that show if we give Lactobacillus casei, for example, we can decrease skin inflammation. I'm just going to briefly touch on eczema, because it might be something that crops up in clinic for people listening. So we have some good evidence now. We don't have evidence to show that you can treat eczema with probiotics, but we do have some evidence. I mean, I think that's coming, but we do have some good evidence to show that actually pregnant women who are potentially at risk of maybe have eczema themselves, for example, if they take probiotics during pregnancy, there's a lower incidence of eczema in babies that are born to those mothers, and particularly in that first year of life as well. So if those probiotics continue in that first year of life. Now, there are loads of different factors that affect that, and of course we looked at all of the different things that affect the microbiota of babies, but actually even genetic changes as well. So we would give pregnant women and we would give newborns probiotics for sure. Now, what I do see in clinic when I see the eczema children is that generally families have gone and they've Googled and they've just started probiotics anyway. So we were chatting about this last night. We were saying actually, even though the Cochrane hasn't quite come out and said we can do that, in general practice, I would say 99% of my patients with eczema have Googled and have started to take a probiotic. And in, anecdotally, I see that it's helping them. So just briefly to finish, I just wanted to talk about my interest in this scenario, and just a recent case study that I looked at in a group of my patients with recessive dystrophic epidermolysis bullosa, where I gave them some probiotics, and I wanted to see if I could improve their gut health, so particularly their constipation. And we gave 4 patients some Simprove for 12 weeks, and we looked at sort of Bristol stool chart, stool frequency, pain on defecation, amount of macrogol gel that they were taking. And actually, it was absolutely phenomenal. What occurred in the children with EB was that they just had a transformative experience where 2 of them could actually stop their macrogol gel altogether, and one of them was just a bit nervous to stop the macrogol gel, I think, but actually it was a profound impact on the children that took this. So my future thoughts to take this further, obviously this is a very small study, is to hopefully look at gut health in pediatric patients with dermatological disorders, to see if not only can we impact on the gut microbiota, but also can I impact on the skin microbiota to improve their skin condition as well as their gut function. So, in conclusion, the recent advances in our understanding of this really complex relationship between the skin and the gut are really giving us new insights into management, and I think almost reversing some of the things that we've been doing for many years in dermatological treatment of patients. And potentially this could have impact not just on the general population for things like acne and eczema, but also some of my patients that have these really devastating skin disorders, and particularly oral prebiotic, probiotic, and diet modification. Thank you so much. It's one of my patients.
Natalie, thank you so much. That was amazing. I'm so sorry, just in view of time, I wonder if we maybe get people to email questions in for you. Would that be all right? Yes. Did everyone just maybe have one burning question for Natalie at all? I think I have 10, but I might have to email you.
Email me. Always happy to have an email. Thank you.
Thank you so much, Natalie.